Today we're going to talk about nursing care of the persons with schizophrenia. Our objectives today, after studying this, you'll be able to identify key symptoms of schizophrenia, develop strategies to establish patient-centered care, recovery-oriented therapeutic relationships with a person with schizophrenia, develop recovery-oriented nursing interventions for the person with schizophrenia, and discuss medications used to treat people with schizophrenia and then evaluate their effectiveness. So some early warning signs of schizophrenia may be social withdrawal, inability to cry or express joy, a flat, expressionless gaze, and we call that a flat affect, a depressed mood, oversleeping or insomnia, being very forgetful, unable to concentrate. This is an acute illness. Psychosis is usually the key diagnostic factor. As with most mental health challenges that we've talked about, the typical onset occurs in late teens, although this can go to mid-30s. So late teens into their 20s, really into their mid-30s with an acute onset. Major deterioration occurring in the first 5 to 10 years of the disorder. Subtle behaviors progress into this disruptive or kind of bizarre behaviors. Patients with schizophrenia are at a high risk for suicide due to their impulsivities and delusions and hallucinations and things of that nature. And we'll talk more about that. As far as goals for recovery, there is no medication that can cure schizophrenia. They need to follow a therapeutic regimen and maintain a healthy lifestyle, manage their life stressors to try not to trigger worsening effects. If they can develop meaningful interpersonal relationships for support systems, or even their family support and involvement is very important. We want to educate to anticipate and expect relapses and know how to cope with it. We pretty much know that patients are going to have relapses. The more important thing is to know what they're going to do about it when it happens and how they're going to be able to cope with it effectively. When relapses occur, sometimes a major reason for that is failure to take their medications consistently. This impairs their cognition and their coping skills, and sometimes it's really hard for them to get back on track. Sometimes they have relapses because of limited accessibility to community resources. Maybe it's lack of income support, being able to afford their medications, or just the stress of financial responsibilities due to lack of income support. There's a degree of stigmatization that around all mental health challenges, but also with some of these major diagnoses like schizophrenia. And then a degree of social isolation can also cause relapses in schizophrenia. Schizophrenia presents with positive and or negative symptoms. And it's important that you know the difference between what is a positive symptom and what is a negative symptom. One of the ways that I can remember them, because sometimes they are hard to differentiate, is a positive symptom is something that is kind of extraordinary or something that's a little more or a little much, okay? So hallucinations, delusions, if a patient is pacing or jumping or yelling or singing or doing something that's just a little extra, those kinds of things are positive symptoms, okay? So these are excessive or distorted thoughts and perceptions. So hallucinations is one or more of the senses. So this could be visual, could be auditory, it could be something that they smell, something that they taste. It could be something that they're feeling that's not there without any extra actual external sensory stimuli. Some different hallucinations. Auditory is hearing voices or sounds. Command hallucinations. This is when the voice instructs the client to perform an action, usually to hurt themselves or others, and this is a very serious hallucination. Visual hallucinations are seeing persons or things maybe in the room that are not there. Olfactory hallucinations, remember that olfactory part of your brain is responsible for smell, and so smelling odors that are not there. Gustatory, experiencing tastes. that are not present. And then tactile, so feeling different bodily senses um, present that have no external stimuli to back up this perception. Delusions. So, what is a delusion? This is a thought that are erroneous, fixed, and false beliefs that cannot be changed by reasonable argument. Okay? So, this is kind of a thought process that they have. It could be a conspiracy theory, it could be paranoia, it could be a delusion of grandeur, thinking that they are, the king or queen and that everyone in the room are their loyal subjects. And it's very difficult to kind of reel them back in and bring them back to reality. Some other positive symptoms, we're going to talk about disorganized thinking and alterations in speech over the next two slides. There are terms we're going to go over specifically for those, and different bizarre behaviors like walking backwards constantly, or standing in a weird position for a whole day, like looking like a statue. So, disorganized thinking symptoms, like different speech alterations, okay? Paranoia, these are some terms. Paranoia, being overly suspicious and thinking others are out to harm you. Referential thinking, finding meaning in signs or thinking the TV is talking about them. So this is finding meaning in something else. Like you're driving down the road, you see a billboard, and you're like, oh, that means that I'm supposed to do this. Or they hear someone talking on the TV in the next room and they think the TV is talking about them. And, therefore they need to do something because they find meaning in all of these things. Autistic thinking, feeling stuck in a thought loop or a rigid logical thought pattern that they just cannot get out of. Concrete thinking, thinking about things literally, like the idiom, he kicked the bucket, which is something we say maybe when somebody died. A concrete thinker might think, like in their head, will imagine a literal bucket being kicked. Verbigeration is repeating of nonsense words, words that don't make any sense, and they just keep repeating them over and over and over again. Metonymic speech is giving meaning to something that represents something else. And a good example of that is in England. They say, we represent people who work for the royal family. We represent the crown. The crown is not a particular person, but a group faction, whoever happens to be in power at the time. So that kind of represents something else. Or people that say, come back to my crib, and the crib means their home and not an actual baby crib. Or when someone says, check out my new wheels, and they mean their car. So it's giving meaning to something that represents something else. Clang association. So this is meaningless rhyming of words, often forceful, such as, oh, fox, box, and locks. And they don't really make any sense together as a sentence. Pressured speech. Talking faster than normal and feeling like they're unable to stop, like there's this motor in their brain and they just have to fill all the silence with words, even if they don't make any logical sense. Stilted language. This is speaking in a formal or unnatural way, and this is often seen in autism disorder as well. But this would be an unnatural, formal way of talking all the time. These are positive symptoms of disorganized speech alterations. We're continuing on, there are more. Echolalia. This is when the client repeats words that are spoken to them almost like they're echoing the person who's speaking. Circumstantiality. This is a circuitous or non-direct thinking or speech that deviates from the main point of the conversation before returning to the original topic. So they're talking in circles. Loose association. This is an unconscious inability to concentrate on a single thought. It can progress into a flight of ideas. Sometimes these different ideas that they're coming out, though, they are at least associated with each other, and therefore it's why it's called loose associations, as opposed to flight of ideas, which, like I said earlier, have different avenues and are not usually interconnected. Tangentiality is a communication disorder in which the train of thought of the speaker wanders and shows a lack of focus, never returning to the initial topic. Flight of ideas. The client's speech moves so rapidly from one thought to another that it's incoherent. It doesn't make sense. They do not flow together. Word salad. This is words jumbled together with little meaning or significance to the listener, like hip hooray, the flip is cast, and wide sprinting in the forest. Neologisms. Made up words that have meaning only to the client. I trained and flitted. This could also be words that are put together that we use, like factoid or cyberspace. Those are also words that are kind of two different words squished together to make a meaning. The next terms I'm going to go over are going to be alterations in behavior. The previous terms were alterations in speech. These terms are alterations in behavior. So there's aggression, which can be passive or forceful, and I think we all know what aggression is. Agitation, again, I think we know what agitation looks like. This is a state of severe restlessness or inner tension. Catatonia. This is a pronounced decrease or increase in the amount of movement. Muscle rigidity or catalepsy may be so severe that the limbs may remain in whatever position they are placed. Echopraxia. This is the purposeful imitation of movements made by others, almost like the patient is looking at you like they're looking in a mirror. You move your arm one way, they move their arm the same way as you. If you turn your head to the side, they'll turn their head to the side. They mirror all of your movements. That's echopraxia. Whereas echolalia, they mimic the words that you're saying. Echopraxia, they mimic your movements like a mirror. Boundary impairments. Impaired ability to see where one person's body ends and another begins. Regressed behavior, when someone behaves in a way that's immature or inappropriate for their age. Stereotypy. Motor patterns that are repeated similar to motor tics, like rocking or caressing their arms with their arms crossed over each other, or marching in place. Now, in autism, this is called stimming. Hypervigilance. This is extremely sensitive to your surroundings. It can make you feel like you're alert and to any hidden dangers, whether from people or the environment. Waxy flexibility. Maintaining a specific position for an extended period of time. And if somebody comes over and moves them, like puts their arm up, puts their arm down, they will move their arm up or down into that position, almost like a flexible candlestick. Impaired impulse control, reduced ability to resist impulses. Many of these symptoms can be attributed to brain deficiencies like decreased dopamine levels. This will exacerbate negative symptoms in behavior and cognition alterations. There is a theory that people with schizophrenia disorder have a disruption in their sense of self. And so this self disturbance is the challenge of distinguishing internal thoughts from external experiences. So typically, this serious sense arises from the consistent interaction between stored information and sensory input. In schizophrenia, disruptions in integrating these sources may lead to a fragmented sense of self, as indicated by cognitive models. So the treatment aims to help clients become active agents in their own care. So part of this disruption in self and what that entails is that it's difficult for someone with schizophrenia to understand like their internal thoughts when you're sitting here and you're thinking to yourself, you know, the thoughts that you're having in your head. It's difficult for them to understand the boundary between those thoughts are in their head or those thoughts are happening in the external environment around them, or that the external sounds that are happening around them are not things that are happening inside their head. So they lose that sense of self. So those are all positive symptoms. Those are kind of extraordinary, over the top, extra movements, extra speech, things that are extraordinary. Negative symptoms, I want you to think emotionless, unmotivated, dull, kind of lacking the general vibe, okay? They're going to have a flat affect, so they're going to be expressionless. They're going to be ambivalent, so being uncertain about their feelings. They're going to have difficulty with emotional expression, so there's going to be some mood swings, shutting down with stressful situations, and avoiding confrontation. Anhedonia, which is little interest in social activities or relationships. Alagia, limited speech, latent responses, quick, short answers, a generally quiet person. Apathy, poor grooming, failure of role responsibilities, lack of motivation or concern. So you see how these are very different from positive symptoms. Positive symptoms where they're more elated and extra, where negative symptoms they're dull, unmotivated, emotionless. Neurocognitive impairment. So the diagnostic criteria. This involves memory, vigilance, and executive function. This can be independent of positive and negative symptoms, often manifested in disorganized symptoms, findings that make it difficult for the person to understand and respond to ordinary sights and sounds of daily living. And that's part of that disruption of self. Or if the client has psychotic thinking or behaviors present for at least 6 months for the diagnostic criteria. And it has to include areas of functioning, including school or work, self-care, and interpersonal relationships are significantly impaired. So that's for at least 6 months. When we talk about schizophrenia across the lifespan, it is very rare for this to be diagnosed in children. It should be ruled out, or we should rule out other disorders before even considering schizophrenia in children. Potential predictors in adulthood, in children, developmental delays, inattainment of speech or motor development, problems in social adjustment, poor academic and cognitive functions. These can be potential predictors for developing schizophrenia as adults. Adults who had childhood cognitive, social, behavioral, and emotional impairment may be at higher risk for developing schizophrenia. In our older adult population, if they've had schizophrenia since young adulthood, there may be a time of improvement in symptoms or a decrease in relapse fluctuations. It is possible to develop schizophrenia later in life, but typically we're looking at that late teens to early 30s time frame. This is found in all cultures, in all countries. It has enormous economic costs. It is usually a lifelong kind of treatment, directly and indirectly with economic costs. Risk factors, genetics and environment. So genetics, again, first degree relatives. If someone with a first degree relative has a schizophrenic disorder, they're at higher risk. It has an insidious onset, so people don't really know when this is going to occur. It could kind of pop in anytime, um, and it has a poor outcome. There's no way to cure it, there's no way to stop it. The best we can do is manage the symptoms. Males and females are affected equally, so there's no difference in gender there. However, males tend to have more severe signs and symptoms, and I think that has a lot to do with males being more impulsive than females. So our safety issues, we always want to do that suicide and homicide assessment. The homicide assessment part of that is if people have command hallucinations and other things, telling them to hurt themselves or others, we need to make sure that, if they're having that, we take that very seriously. Um, any potential aggressive actions towards staff and other patients when they're admitted to the inpatient unit, we need to address. We must determine if a patient is displaying any negative symptoms or a side effect of antipsychotic medications, or if they're actually depressed or feeling like they're having demoralization. We need to know if they're having any substance abuse. Recovery is going to be a long-term journey, and they may need hospitalization for stabilization and medication adjustments. Nurse and patient collaboration in developing recovery-oriented strategies during periods of relative stability. So like other disorders we talked about, we're not going to be able to achieve recovery-oriented goals or education during times of hallucinations or delusions, or any of those positive or negative symptoms. We really want to do that during periods of stability once we get medications on board and get this patient stabilized. Patients often have a very difficult quality of life. So we want to assess how this can be improved. Are there any resources that they could benefit from? Simple changes may greatly improve the quality of life for this patient, whether that's helping them with medication adherence, transportation, groups, arranging for a different roommate if they're inpatient if needed, improving their access to social activities, encouraging them to participate in the groups. And then for transportation needs, there's only so much we could do, but we can provide taxi vouchers when they leave the hospital, maybe help set them up with getting a bus card for doing local transportation. Again, with just like some of our other mental health challenges, we're going to do that strength assessment, and that's not how much they can bench press, it is what are they already doing well. So identify their personal and family strengths. Their family support is critical. And they're also going to be the one to be able to see when the patient is starting to spiral. Intellectual ability and coping with stress. So some possible questions to ask them, like what do they do for relaxation or fun? How do they manage their stressful events? How do they cope with voices, thoughts, or impulses? Who do they talk to when they're upset? Like, who's their support person that they go to? And are they hopeful for the future? And this kind of goes along with a suicide risk assessment. There's a variety of nursing care needs that emerge at different times, right? So safety is a focus during an episode of psychosis. Sleep might be a severe problem at another time. Depression may be a priority at a later time. Hygiene may be an issue at any time. And motivation may become an issue. So we always want to prioritize the severity of the current responses happening during one of their episodes. Therapeutic relationships, we must develop trust, with this person, and that could be very difficult if they're having any kind of paranoid delusions. Accept the person as a worthy human being and infuse the relationship with hope, okay? Consistency is the true foundation of trust. Either keep your promises or do not make them. And that is so true. If you say you're going to go get them a cup of water, make sure you come back with that cup of water, because even that simple act will help develop trust with that patient. Maintain eye contact if culturally appropriate, and use their name when you're talking to them, and that will go a long way with developing a trust and therapeutic relationship with that client. This may take time to develop a relationship, and you may want to have short, time limited interactions with them, but be consistent, keep your promises, and create recovery oriented goals. Medications, when providing someone care with schizophrenia, clients may have too much dopamine, and medication choice must be individualized based on their symptoms, like if they're having hallucinations and delusions or negative or positive symptoms. Um, but the first generation antipsychotics like Haldol and the Zines, right, the medications that end in ZINE, so those first generation antipsychotics, those are pretty effective in treating the positive symptoms by blocking dopamine in the dopamine pathways of the brain, okay? Our second generation antipsychotics, those Dones and Penes, those are effective in treating negative and positive symptoms by blocking serotonin and dopamine in the brain. Sometimes we give these antipsychotics right away, and they really are to help with hallucinations and delusions. It can take, and they can help with the hallucinations and the delusions right away, but they'll take 1 to 2 weeks to affect and change of other symptoms. And usually a trial of 6 to 12 weeks will be done before they make any changes to the medication regimen. There is a picture in your slide here about your typical antipsychotics, the higher potency particular antipsychotics, and then there's some lower potency ones. You don't need to know the difference between the high potency and lower potency. But I thought this was a good graph that just shows that these medications, these first generations, they block dopamine receptors, which alleviate the positive symptoms, okay? And then this next slide, your atypical antipsychotics, those second generations, they block the dopamine receptors, again, that alleviate positive symptoms. And they also block the serotonin receptors in the brain. Complications sometimes of taking, especially these typical antipsychotics, the first generation, and most commonly of those first generations, Haldol, can cause this NMS, neuroleptic malignant syndrome. This is a life-threatening condition. It's caused by dopamine levels being dangerously low, because remember we're blocking those dopamine receptors. And this can cause severe muscle rigidity, a rapidly elevated temperature with rapidly accelerating cascade of symptoms. Okay, so early recognitions of symptoms is ideal. We want to withhold any antipsychotic medication that may be causing it, and we're going to give dopamine agonists to increase the dopamine levels again, and a muscle relaxant for spasms. Frequent vital sign monitoring is needed, along with laboratory tests and checking CK levels from the severe muscle rigidity to make sure that those are within normal limits, and then supportive measures. So typical antipsychotic signs and symptoms, so these are your first generation, your extrapyramidal side effects, Parkinsonianism, dystonic reactions, akathisia, and tardive dyskinesia. And there's a spot here for you to write in what those terms mean, and we'll go over those in class. Anticholinergic crisis is a life-threatening condition. This is due to an overdose or sensitivity to drugs with anticholinergic properties. As you recall on our depression lecture, there are some like TCAs that cause uh, cholinergic issues, but they're not the only things that cause these anticholinergic issues. Sometimes antipsychotics can as well. But signs and symptoms: hot as a hare, blind as a bat, mad as a hatter, dry as a bone. Okay, so this is self-limiting, usually 3 days after the drug's been discontinued. So the treatment is really discontinuing of the medication, and in severe cases, a gastric lavage with charcoal. So if we see these symptoms, they're hot, they're flushed, they're having, blurry vision, confusion, and little to no urinary output or urinary retention, then we need to consider that they're having an anticholinergic crisis. Some patients find these effects pleasurable, right? So some over-the-counter cough medications like Sudafed, um, if taken too much, can also cause these effects, and which is why you used to not be able to readily buy those over the counter anymore. Toxic dosages may experience mild delirium with disorientation and hallucinations. Lesser doses may cause the patient to experience greater social ability and euphoria. All right. When they stop taking those medications, they're going to have a cholinergic rebound. So this happens when you abruptly stop taking the anticholinergic agent, especially problematic if patients discontinue other medications at the same time with anticholinergic properties. And symptoms can include vomiting, excessive sweating, altered dreams, and nightmares. And those resolve within 3 days or so. I now want to talk about schizoaffective disorder. So this is a little bit different than schizophrenia. So schizophrenia, when it's diagnosed, happens, someone lives with this disorder every day. But schizoaffective disorder, this is characterized by periods of intense symptom exacerbation alternating with periods of adequate psychosocial functioning, which means think of it this way. Someone is affected occasionally by schizophrenia. Okay, so that times this is marked by psychosis and other times by a mood disturbance. When psychosis and mood disturbance occur at the same time, then a diagnosis of schizoaffective disorder is made. This person may have these symptoms once and then maybe go 2 years of being symptom free and then have them again and go into a period of time where this happens again. They're more likely to exhibit persistent psychosis than patients with a mood disorder, and the long-term outcome is generally better than that of schizophrenia, but worse than that of a mood disorder. So it's a little bit harder to control than maybe bipolar disorder, but the long-term outcome is generally better than schizophrenia because this person is not dealing with this on a daily basis. Next, I want to talk about delusional disorder. Delusional disorder is distinct from schizophrenia and cannot be diagnosed if the person meets criteria for schizophrenia. And that's because a person with schizophrenia can also have delusions. But a person with delusional disorder may just have delusions and not have schizophrenia. Someone with delusional disorder has a logical, stable, well-systemized delusion that occurs with absence of other psychiatric disorders. Okay? So this is a fixed false belief that cannot be changed by conflicting evidence. They may think that there is a conspiracy theory, maybe someone is plotting to murder them, or aliens are going to abduct them, and they're kind of stuck in this particular storyline of a delusion. But they don't have any other psychiatric illnesses per se, no other diagnoses, and so this really stands alone. The most frequent type is a persecutory delusion, and this is the paranoid thinking that can be severe, usually that law enforcement is bugging their phone, for example. People are reading their emails, maybe that they have a tracker on them, things of that nature. Delusional disorder refers to a condition in which the individual displays one or more delusions for 1 month or longer. So this has to go on for at least a month, if not longer. Situations that can occur in real life that are plausible in the context of the person's ethnic and cultural background or clearly impossible. So this could be that their story could make a lot of sense and it could be totally plausible within the context of their ethnic background, or it could be clearly impossible, like aliens abducting them. So our interventions overview, we want to approach patients calmly and quietly from the front, speak in clear, calm, unhurried voice, adopt an accepted and consistent approach. We want to avoid startling these patients because they have some hypervigilance already, and we don't want to exacerbate any paranoia that they have. We want to reward positive behavior, provide reality-based explanations for distorted body image or hypochondrial complaints. So that would be exaggerated medical conditions that they think they have, or something of that nature. Don't argue with the patient about whether their hallucinations are real or not. Clarify that you don't perceive the stimuli as the patient does. One of the best things you can say is, I understand that you see something in the room, that you see that there is a skunk in the room with us. I believe you that you see it. I do not see it. Could you please tell me more about what you see? Or, I understand that you're hearing voices. I believe you that you're hearing voices. I do not hear them. Could you please tell me what they're saying? That way you are telling the patient that you believe them. You're not minimizing what they're experiencing, but you're not playing into their delusion. You're not playing into their hallucination. And you're also asking them to let you know and describe what it is that they're seeing or hearing. Focus on the feeling about the delusion rather than its content. Don't reinforce the delusion. Don't say, yes, the aliens are coming, or, oh no, we better hide. Engage the patient in present-oriented, reality-based activities and interactions. Set limits on inappropriate behavior. So if they're doing something they really shouldn't be doing and they feel like they can't stop, maybe say, like, you can do that one more time and then you can't do it again. Offer simple and matter-of-fact explanations for the environmental safeguards, drugs, and policies. Build trust, but be honest and dependable. Don't threaten and don't promise things that you can't fulfill. Patients with psychiatric challenges, if you break promises to them, it is the hardest thing to build back trust. Administer their prescribed medications. Ensure that the patient has swallowed the drug and is not cheeking it. And sometimes they don't want to feel or lose the feeling of whatever they're feeling. It depends on if they feel good about it or not. Obtain a baseline white blood cell count before starting clozapine therapy. Dilute an oral dose of haloperidol in water or beverage immediately before administering is usually recommended. Obtain baseline blood pressure measurements before starting any therapy. We always want to have baseline vital signs, ECG, and labs before we start any kind of antipsychotic therapy. Evaluate the patient's ability to carry out activities of daily living, provide assistance as necessary, and encourage the patient to participate in as much care as possible. If necessary, break down the tasks into simple steps that the patient can complete. Avoid promoting dependence. You do not want them to become dependent on you or their family members or anyone else. Independence is ideal. Maintain a safe environment. Minimize stimuli by turning off TVs, radios, closing curtains if there's a busy street nearby. Institute suicide precautions and develop a safety plan with the patient that includes a list of appropriate coping strategies and sources of support. Remove all potentially harmful items from the patient's environment. Then observe for changes in behavior that may signal for an increase in risk and violence, such as irritability, intimidating behavior, motor restlessness, loud speech, or overt threats. Implement the least restrictive environment for the patient. So really safety first, maintaining their environments, making sure that they're safe from themselves and to others. And that concludes this discussion on schizophrenia, schizoaffective disorder, and delusional disorder.